Hello, I'm Lizza Hendriks, pulmonologist specialized in thoracic oncology from Maastricht University Medical Center, the Netherlands, and I will give an overview about the evolving landscape of targeted therapies. My disclosures. So the agenda for today. First, I will give an overview about evidence-based strategies for developing targeted drugs. Then I will touch upon biomarker-agnostic targeted therapies and their role in non-small cell lung cancer treatment. And for non-small cell lung cancer, I will go into data analysis and integration in clinical practice to enhance decision-making processes for optimal patient outcomes with consideration of the role of co-mutations and patient-related factors, therapeutic drug monitoring, resistance paradigm, and emerging targets. First, to evidence-based strategies for developing targeted drugs. First, I will start with a polling question. Do you think tumor-agnostic therapies work? Yes or no? Please vote, and then I will tell you my answer. Well, I think it's a little bit nuanced. I think for some tumor-agnostic targets, these therapies indeed do work. So I will show you some examples where it works, and for some where it doesn't work in the upcoming slides. I think first we need to think of what do we want with systemic therapies. Historically, we gave a one-treatment-fits-all to all patients, but now we're into the biomarker space and we want to personalize treatment. Because, and this is already a quite old figure, we know that patients with an oncogenic driver receiving targeted therapy, seen in the Kaplan-Meier and orange, have a longer survival than those with a driver not receiving targeted therapy, in blue. And that's the same survival as patients without a driver without targeted therapy. But if you then move to tumor-agnostic therapy, that's a little bit different than treating one driver and one tumor. Tumor-agnostic therapy is a type of therapy that uses drugs or other substances to treat cancer based on the cancer's genetic and molecular features, without regard to the cancer type or where the cancer started in the body. A tumor-agnostic therapy uses the same drug to treat all cancer types that have the genetic mutation or biomarker that is targeted by the drug. And you can see it depicted in the figures below. So you don't group the patients by the same type of cancer, as is shown in the middle, but you group the patients based on the same genomic alteration, for example, an anthrax fusion. And conventional trials are not feasible in the agnostic setting. There are quite some challenges associated with collecting clinical trial data to assess treatments for rare cancers and rare genomic alterations, such as tumor-agnostic treatments, including the low prevalence of the disease, so small patient numbers. Therefore, it's challenging to identify and enroll patients into clinical trials. And because of the patient numbers are small, often there's a lack of an established comparator in some cases. If you then look into the characteristics that therapeutic agents should have for tumor-agnostic indications, then you can divide it into biological, statistical, and regulatory characteristics. For biological, you need to have an established histology-independent mechanism of action. You need to have an absence of histology-specific mechanisms of resistance. You need to have clinical activity across histologies, efficacy in adults and if the target is present in kids, also in pediatric patients, and of course clinical safety. Statistical things can be difficult, as randomization might be difficult or not feasible due to the low number of patients, so you need to have an effective design to enable evaluation of subpopulation heterogeneity. And you need to consider the evaluation of a single indication phase 2 data prior to pooling, and responses should be surrogate of clinical endpoints. And for a regulatory standpoint, you need to have a validated biomarker, and you need to show substantial clinical activity leading to belief of superiority versus standard of care. And as numbers are usually quite small, you need to have post-approval efficacy and safety monitoring. And sometimes tumor-agnostic targeted therapies are susceptible to over-application when you extrapolate for use in tumor types not included in a trial based on histology-agnostic therapies. We have some mechanisms to grade the targeted therapies, and we have the ESMO scale for clinical actionability of molecular targets, or ESCAT. And you can see on the figure on the left that tier 1 means ready for routine use, and then it goes down to investigational, tier 2, hypothetical target, tier 4, tier 3, development, tier 5 and lack of evidence tier 10. And I think for ready for clinical use, if you look at the tumor agnostic space, then you need to look at level 1C, so below in the table. 1C means that clinical trials across tumor types or basket clinical trials show clinical benefit associated with the alteration drug match with similar benefit observed across tumor types. And the clinical implication means that the access to the treatment should be considered standard of care. But sometimes it's quite difficult to compare the efficacy of cancer therapies between subgroups in basket trials. And I think this publication in Cell Systems has a quite elegant statistical method to evaluate the efficacy of targeted therapies. So this is a quite rigorous approach to permutation testing using empirical null distributions that can identify previously overlooked opportunities for use of targeted therapy in genetically defined cancer types. I think it's a quite interesting article to read to see how you can improve the evaluation of these type of drugs in rare patient populations. Moving then on to biomarker-agnostic targeted therapies and their role in non-small cell lung cancer treatment, I again would first like to start with the polling questions. What are some examples of biomarker-agnostic targeted therapies in cancer? Is this NTRK? Is this RET? Is this BRAF V600? Or is it all of the above? Please vote. And I think for these 3 targets it's all of the above. And for the first 2 I will show you some data in the upcoming slides. And there are quite some targets with potential for agnostic drugs. If you look at these types of primary tumors, then you can see that NTRK, RET, BRAF V600, but also MSI high and TMB high are present in different histologies. Focusing on the oncogenic drivers, for NTRK it's mainly found in thyroid and head and neck cancer, but also in non-small cell lung cancer. For RET it's mainly found in thyroid, and depending on the type of thyroid cancer, it's a fusion or a mutation, or a non-small cell lung cancer, and then it's a fusion. And BRAF V600 mutations are mainly found in melanoma, thyroid and colorectal, but also in non-small cell lung cancer. And we have quite some tumor-agnostic approvals, starting in 2017 already, with immunotherapy pembrolizumab in mismatch repair deficient or MSI-high cancers. Then in 2018, 2019, larotrectinib and entrectinib in NTRK fusion-positive cancers. 2020, 2021, pembrolizumab and dostarlimab, again immunotherapy in TMB-high or mismatch repair deficient MSI-high cancers. And 2022, dabrafenib, trametinib, BRAF V600. And the last one, September 2022, selpercatinib in RET fusion-positive cancer. So what are the data for these approvals? So first focusing on NTRK, larotrectinib and entrectinib. These approvals were based on pooled analysis of phase 1 and phase 2 trials. For larotrectinib over 200 patients and for entrectinib over 100 patients. And you can clearly see in both figures that regardless of the primary tumor histology, these drugs do result in quite deep responses. Response rates are above 60%, and when there is a response, the duration of response is quite long. Median progression-free survival, I think, also very encouraging, and median overall survival either not reached or above 2 years. But I think you should be cautious. These are, again, small numbers, different tumor histologies, so you cannot compare these trials. We even have repotrectinib, also again for NTRK tumor agnostic, phase 1, phase 2 Trident-1 trial. NTRK negative and NTRK TKI pre-treated. Again, you can see in both waterfall plots that this drug results in deep and long-lasting responses across different tumor histologies. Moving on specifically to non-small cell lung cancer, again NTRK, larotrectinib and entrectinib, of course smaller numbers, but you can see the same type of waterfall plot specifically focusing on non-small cell lung cancer. Response rates above 60 to 70%, durable responses, and encouraging median progression-free survival and median overall survival. But again, because of low numbers, you cannot compare these clinical trials. Moving on to RET, first the tumor-agnostic data for both calcitinib and selpercatinib. Calcitinib on the left in the ARROW phase 1-2 trial, and on the right, the Libretto 001, selpercatinib. Again, you can see encouraging responses with good duration of response, median progression-free survival, a little bit lower, but median overall survival, I think, not bad for these patient populations. For non-small cell, we have even more data. So the ARROW phase 1-2, 75 patients. Here, the treatment-naive cohort with pralsetinib, response rate above 70%, duration of response not reached, median progression-free survival 13 months, and median overall survival not reached. The accelerated lung phase 3, randomizing patients to first-line pralsetinib or chemotherapy with or without immunotherapy, is ongoing, but we already have the Libretto 430 trial, a phase 2 trial, evaluating selpercatinib versus platinum-doublet chemotherapy with or without immunotherapy in the first-line setting. And you can clearly see that selpercatinib improves progression-free survival compared with chemotherapy with or without immunotherapy, with high response rates, durable responses, and a median progression-free survival just over 2 years. So, unfortunately, not all are success stories. On the left, you see for non-V600E BRAF mutations or fusions, the trametinib data, with response rates of only 3% and a median progression-free survival of below 2 months. In the middle, you see AZD4547 in FGFR, deregulated either amplification or fusions. Again, low response rate, low progression-free survival. And on the right, you see TDM1 and R2 amplified non-breast cancer. Again, disappointing data. So for some of these targets, it could be that it is not the actionable target or that the drug is not working that well. So the key points for this part is that testing for oncogenic drivers is becoming increasingly important across tumor types. And targeted tumor-agnostic therapies work for several oncogenic drivers. RET, BRAF V600 and NTRK have approved therapies, and I showed you the RET and NTRK data, but for BRAF V600 there are also good data, but not all are success stories and continuing research is needed. Moving on to the next part, the data analysis and integration in clinical practice to enhance decision-making processes for optimal patient outcomes. And then I will move and focus on lung cancer clinical practice, because I think for lung cancer, the choice for the right treatment is becoming increasingly difficult with all these new approvals. We have multiple targetable oncogenic alterations, and the development and introduction of these new agents is accelerating, as you can see in the figure on the right. And if you look at the recently published ESMO guideline, we have 10 targetable agents with sometimes multiple options for drugs available, either in first line or in second line. And here are only the EMA and FDA approved agents mentioned, but multiple others are in development. And as we know, for non-small cell, all these targeted therapies result in high response rate. You can see on all these waterfall plots that response rates are high, and I didn't show the data, but responses are durable, and you can see the progression-free survival in the figure. And for some of these targeted therapies, we have long-term survival data. For example, for FLAURA, EGFR, the osimertinib arm, the 5-year overall survival is approximately 40%. For ALEX, the alectinib arm, the 5-year survival is above 60%. For ROS1, crizotinib in the profile 1001, again, encouraging 5-year overall survival of 50%. And the abrafinib, trametinib, also encouraging long-term survival with 22%. But we know that some patients do not benefit, and we also know that the presence of co-mutations can negatively influence the survival. And here I show you some examples. On the left side, you see the GENIE data for EGFR-mutated non-small cell lung cancer with osimertinib first line. And you can clearly see if the patient had a co-mutation, for example, a TP53 mutation, with or without another tumor suppressor gene, then you can see that the overall survival is clearly inferior to patients without co-mutations. On the right, you see the same for the CROWN phase 3 data, so ALK-positive non-small cell lung cancer, lorlatinib compared with crizotinib in the first line. You can see in blue lorlatinib TP53 negative, the uninterrupted line, and TP53 positive, the dashed line, and the same for crizotinib in green. Again, you can clearly see that patients with a TP53 positive tumor have an inferior median progression-free survival. So maybe we need to escalate treatment in non-small cell lung cancer with co-mutations. And an example of a clinical trial ongoing is a phase 3 trial evaluating olmesartanib with or without chemotherapy in EGFR-positive non-small cell lung cancer with a tumor suppression gene as a co-mutation. And I think in the end, we further need to individualize the treatment of these patients based on co-mutations. Brain metastases are also relevant for treatment decisions, and here I show you some examples. We need CNS-penetrating TKI, as you see in the Kaplan-Meier of the figure on the left. The CROWN phase 3 again, at the baseline brain metastasis subgroup, so lorlatinib compared with crizotinib first line. And you can clearly see that the patients treated with lorlatinib, so a CNS-penetrating TKI, have a very low cumulative incidence of CNS progression. For EGFR, we know that osimertinib is superior to the first-generation EGFR TKI in the treatment and prevention of brain metastasis. But I think quite surprisingly, in the FLAURA2 phase 3 clinical trial, so evaluating osimertinib with chemotherapy versus osimertinib monotherapy in the first-line setting, it was shown that the addition of chemotherapy improved the outcome of patients with baseline brain metastasis, despite the fact that chemotherapy has a relatively poor CNS penetration, and I think more research is needed to explain these outcomes. One of the explanations could be that these patients have a higher disease burden and are in need of a faster response, but I think we don't know it at the moment, and something for further research. Another thing to personalize therapy further in the oncogene-driven space is the use of ctDNA and ctDNA clearance. So on the upper left, you see the FLAURA PFS data based on baseline ctDNA, and you can clearly see that those without detectable baseline ctDNA have a superior survival compared with those with baseline detectable ctDNA. And this holds true for osimertinib, but also for the first generation TKI. If you look at the lower bottom, then you see the FLAURA PFS data based on ctDNA clearance. And again, it's clearly shown that for patients without ctDNA clearance, median progression-free survival is inferior compared to those who achieve ctDNA clearance. And we know for several other oncogenic drivers that similar data exist. And again, this knowledge is used to build clinical trials. So here an example of a clinical trial in the EGFR-mutated non-small cell setting. So patients treated with osimertinib, plasma EGFR testing, and patients who don't clear ctDNA or become positive are randomized to continue osimertinib or are randomized to osimertinib, and then chemotherapy is added, hopefully to further personalize clinical therapy. Another thing I think that's gaining increasing interest is the use of therapeutic drug monitoring. So evaluating plasma levels of the targeted therapy to guide treatment decisions. On the upper left, you see a Dutch clinical trial evaluating whether an intervention in patients with a low plasma level of the targeted therapy results in better outcomes than when there is no intervention. And you can see for the group in red compared to the group in blue that patients with a low plasma level with the intervention to increase the plasma level have better outcomes. However, the other group for patients with adequate plasma levels does have an inferior outcome. And I think the drawback here is that TKI data for non-small cell were largely lacking in this clinical trial. However, if you look at the lower left bottom, then for alectinib retrospective data suggest that a low plasma level is associated with a poorer PFS. And similar retrospective data for crizotinib as well as dabrafenib, but not for osimertinib, exist that low plasma levels are associated with poorer PFS. And again, this data is used to build a prospective randomized clinical trial, and the Dutch ADAPT-ALEC is ongoing, so patients with ALK-positive non-small cell lung cancer treated with alectinib will be randomized to TDM-guided dosing, where the dose is increased if the plasma level is below a certain level, in the absence of unacceptable toxicity or just fixed dosing, and the primary endpoint is median progression-free survival. Then moving on to mechanisms of TKI resistance, we know that they are heterogeneous, and we also know that they can be used to further personalize targeted therapy. So you can have on-target resistance mutations, you can have bypass resistance mechanisms like MET2 amplification, Unfortunately, you can also have histological transformation to small cell or to squamous cell carcinoma, and quite a lot is still unknown. But we know that depending on the mechanism of resistance, we can personalize the treatment for these patients. So for example, for MET amplification, you can give a MET TKI or an antibody-drug conjugate and add it to the EGFR TKI. And in general, the responses are 30 to 40% with a median progression-free survival of 4 to 5 months. But you can also sometimes give antibody-drug conjugates if there is no known targetable resistance mechanism, and these more unselected strategies also result in response rates of 30 to 40% and a median progression-free survival of 6 months. But in the end, these data are mainly derived from single-arm phase 2 trials, and we need randomized clinical trials against standard of care, and fortunately several are ongoing. There are also new methods of action to enlarge the treatment options and increase the number of targets. So other targeted therapies, small molecule inhibitors, for example, as KRAS G12C. You can use bispecific antibodies, for example, to EGFR and MET, and antibody-drug conjugates, as I already discussed in the previous slide. And one of these new targets is EGFR exon 20 insertion, and here I show you the Papillon phase 3 data. In this trial, patients with metastatic non-small cell and an EGFR exon 20 insertion mutations were randomized to amivantamab chemotherapy or chemotherapy alone, with a primary endpoint of progression-free survival. And amivantamab is a bispecific antibody against EGFR and MET. And as you can see in the Kaplan-Meier curve on the right lower part, the median progression-free survival was clearly superior for the combination of amivantamab chemotherapy compared with chemotherapy alone, with a median of 11.4 months compared with 6.7 months. Another relatively new target is the R2 mutation. Here I show you the Destiny Lung cohort 2 data. So trastuzumab deruxtecan, an ADC against R2, is quite effective in patients with an R2 mutant metastatic non-small cell lung cancer, as you can see in the figure on the right, both in pre-treated and treatment-naive patients. And in the end, I think we further need to personalize therapy and test whether certain targets can be approached in a tumor-agnostic way, or that the treatment should still be based on a tumor type. In the Netherlands, we have the drug rediscovery protocol, so the drug. Then we have different drugs, and for each drug, different cohorts are made based on the tumor type and the profile of the patient. And in the end, a couple of patients are treated, and depending whether there are patients with clinical benefit, there are expansion cohorts to see whether the cohort can be declared successful or not. I think this is a way to develop targeted therapies for rare oncogenic drivers. Another example is the iBasket trial. So that's a modular basket clinical trial that consists of 2 parts, a profiler part and a basket part. And if you look at the iBasket part, there are different modules based on different oncogenic drivers. And to the best of my knowledge, research results are still awaited. So for non-small cell lung cancer, the key points are that there are an increasing number of oncogenic drivers with targeted therapies available. Patient and tumor-related factors, as I've shown you, play a role or will start to play a role in treatment decisions. And I think upfront broad testing is increasingly relevant to detect all these oncogenic drivers, but also these co-mutations. And I would like again to start a polling question. What do you think is the largest bottleneck for precision medicine? Is this awareness? Is this sample availability? Is this the availability of assays including costs? Is this timely reporting and interpreting of results? Or is this drug availability? Please vote. And for me, I think there is not a very clear answer. It really depends, I think, on your situation. I think we really should increase awareness amongst physicians that we should start and that we should have broad testing. But sometimes it's difficult to get a good sample. Sometimes liquid biopsy can help. But if you are in a resource-lacking environment, then sometimes assays are not available. Or if you're in a low-income country, cost can be a huge problem. Timely reporting and interpreting of results can be a challenge for some colleagues. And unfortunately, drug availability is not the same across countries, so this can also be a challenge. And I think in the end, we need to work together to improve all these items to increase the access of these targeted drugs for our patients. And with this, I would like to hand over to Dr. Peters.